Actually, my topic today will be about one of the important differential diagnoses in managing patients who is presenting with hyperthyroid state rather than hypothyroid state. Previously known, this case of what is told before that we have a subacute thyroiditis was nominated before as a decurvian thyroiditis and even subacute form of non-subacute thyroiditis, granulomatous thyroiditis, pseudotuberculous thyroiditis, pseudo-giant cell or even giant cell thyroiditis, and sometimes we call it migratory or creeping thyroiditis or stroma granulosa. Actually, why it's called sometimes the migratory or creeping thyroiditis, I will tell you during the clinical presentation of these cases. Usually the condition starts mostly after viral infection. So we can say that we have an important viral origin and usually lasts from a few weeks to few months, and sometimes a tendency to recur. What about the etiology of subacute thyroiditis? Actually, the exact cause can be rarely established, but sometimes, as I said before, it's a tendency to occurring after an upper respiratory tract infection, so and even with sore throat, so could be induced by viral infection, and it occurs during the development. This problem of destruction of the thyroid gland can induce some form of cell-mediated immunity against this various thyroid cell release in circulation due to destruction. So we can find parameters of cell-mediated immunity in circulation because of this destruction of thyroid gland. A lot of research about the cause of this subacute thyroiditis, and usually you cannot find an exact cause, but a lot of cases was discovered after infection by mumps, but most of the several viral infection can induce this form of subacute thyroiditis, like measles, influenza H1N1, or adenovirus, even infectious mononucleosis, and HIV, cat scratch disease, and also Coxsackie virus. Very interesting that cases with subacute thyroiditis, even more than 70% of these cases, they found that an histocompatibility study found that it related to HLA-B-W35. So we can have a familiar occurrence of this form of thyroiditis, what we say about subacute thyroiditis. So we can summarize that we have susceptibility of occurrence of subacute thyroiditis in genetically patients when we have a certain viral infection induces this form of subacute thyroiditis. What about the incidence and prevalence of this form of thyroiditis? It presents 5% of cases presenting with thyroid illness. It approximately 1/8 of the incidence of Graves' disease, the famous form of hyperthyroid state. And although the disease is described in all ages, but usually it's very rare in children. But then also it has male predominance. It's from 1.96 to 1. Most of the thyroid diseases are more common among females, and it can be very used or rarely induces hyperthyroid state or thyroiditis in pregnancy, and usually this one occurs in the first trimester. Usually subacute thyroiditis present characteristically by severe pain and extremely tenderness in the thyroid region and with difficulty in swallowing. But still a small number of patients have been noted to present by painless or even minimally painful thyroid problems. And sometimes they have a transient vocal cord affection. And at the time when the patient starts to have pain, sometimes it occurs in one pole and then completely spreading to the whole, affect the gland. And the pain may relate to the jaw or even the ears. We have the constitutional symptoms like malaise, fatigue, and myalgia, and even arthralgia, and sometimes fever, very high fever reaching 40 degrees centigrade. Usually the disease peaks in 3 to 4 days and sometimes subsides within 1 week, but most of the cases it lasts up to 3 to 6 weeks. And several accounts of the diminishing intensity of the extending may extend over many years or even many months for this patient. Usually thyroid gland is enlarged 2 to 3 times or even more the normal size and smooth and firm consistency, and sometimes it's occasionally confined only to one lobe. Approximately 1/2 of the patients presenting the first few weeks of the illness will have symptoms of thyrotoxicosis. We all know about nervousness, heat intolerance, palpitation, even ventricular tachycardia, increasing sweating. And usually these symptoms occur due to the release of the damaged thyroid gland through this release of the performing thyroid hormone inside the gland. And rarely, sometimes they present by thyroid storm and even leading to adverse cardiac outcomes. As this process subsides, sometimes we have transient hypothyroid state in 1/4 of the cases. Ultimately, thyroid function returns to normal, and permanent hypothyroid occurs only in less than 10% of cases. Occasionally, the condition may be painless, which is the problem we have with one of the main characteristic features is the severe pain, and present by fever of unknown origin, mimicking another cause, and even some form can be diagnosed as having temporal arthritis. Some cases have elevated liver enzymes related even to effect of thyroid. What about the diagnosis of subacute thyroiditis? Laboratory examination may disclose moderate leukocytosis and very striking elevation of ESR, more than 100. And mild anemia and hypergammaglobulinemia, the elevation of the ECR is very important. It's one of the striking features of subacute thyroiditis. And this characteristically, we can have to find a combination of a very high ESR in a patient with high T4 and T3 and even thyroglobulin concentration with low thyroid uptake and TSH, and absent or even low titer of thyroid gland antibodies. While the estimation of thyrotropin receptor antibodies is very important in patients with Graves' disease, which is very highly significant in patients with Graves' disease, sometimes in a very rare conditions or a very small amount of patients could be having in patients with subacute thyroiditis, but still this titer is very low. What about imaging in these cases with subacute thyroiditis? 99 technetium per technique usually signifies a very low uptake, because it depends on the iodine uptake of the gland. But on the other side, when we use this imaging technique by using technetium sestamide or technetium tetraphosamine, we have a high uptake because it is manipulating by the acute inflammation in the thyroid gland. So per technique, what we use it commonly in Egypt, will find very low or absent uptake. We don't use sestamide in Egypt, so cannot find it. What about the standard ultrasonographic criteria patient? This is non-specific. We find only hypoechoic appearance of the affected tissue. The problem is we haven't confined to one lobe or a small part of the gland. But when we apply the newest sonoelastography, we'll find that very high stiffness in this patient with subacute thyroiditis and can be differentiated from some form or other inducing stiffness in the thyroid gland. And when you use T1 and T4 to diffusion wide magnetic resonance imaging and even 18F, FDPG, and PET scanning, we can differentiate between this and Graves' hyperthyroid. But actually, we don't need this. What about biopsy? Fine needle aspiration is diagnostic of inducing inflammation inside the cell, but still most of the patients have severe pain, so we refuse to do biopsy. But this biopsy is important when we are suspecting malignancy underlying in a localized area of the gland administrated by hypoechoicity and increasing size, as I'm going to mention, in the patient by ultrasonography. During the initial phase, the radioactive iodine uptake will be depressed or completely absent, and the concentration of T3T4 will be high due to the concomitant release of the non-hydrolyzed iodoproteins like thyroglobulin. Will find the serum thyroglobulin will be very high, and at the same time, I said TSH will be very low. Why TSH is low? You can analyze it. The TSH suppression in this patient with subacute thyroiditis, they demonstrate that this suppression of detectable level of TSH, while patient with Graves' disease, they have no undetectable level of TSH. But subacute thyroiditis, you have a low detectable level of TSH. And even TSH response to RH is absent, because administration of TSH will fail even to increase uptake by radioactive iodine, because completely suppressed by damaging thyroid cells, and the process subsides, then T3 and T4 goes down again, and thyroglobulin and TSH rise up again. Later during the recovery phase, the radioactive iodine uptake will improve with the resumption of the ability of thyroid gland again to concentrate iodine, and the T4 concentration will go down, and TSH level will go up. Ultimately, after several weeks or months, all the parameters of the thyroid gland will return to normal. But still, restoration of iodine stores would need more than 1 year to replenish again the thyroid gland iodine storage. In only 2% of cases with subacute thyroiditis, they could trigger reactive B cell, autoreactive B cell to produce TSH receptor antibodies. So you can find these TSH receptor antibodies in less than 2% of cases. And this finding may be potential explanation by the apparent occurrence of Graves' disease, which is also already this rare situation following an episode of subacute thyroiditis. So the triggering of this autoreactive B cell to induce it against thyroid TSH receptor, we can find it and can induce again Graves' disease following this attack of SA. But still, this is very less than 2% of cases. This diagram showing stages of subacute thyroiditis from hyperthyroid state to hypothyroid state and go back to the euthyroid state. And usually it lasts longer time in the hyper than the hypo, unless something happens and more destruction of the tissue, and it can induce hypothyroid state in longer duration. What about the differential diagnosis of these cases? The patient presenting is classic with painful neck problems. Most of the doctors are going to prescribe antibiotics and follow up. So the patient is being mistaken. After a while, they found that they have a thyroid problem. And what is an acutely enlarged tender thyroid, radioactive iodine uptake nearly zero with elevated and over T3 and T4 and thyroglobulin and high SR, which is very important. The diagnosis is almost certain. And circulating thyroid antibodies are absent or even low titer. Amongst the diagnostic alternatives, the uncommon presentation of thyroid cause in infectious thyroiditis, but rarely a fever of unknown origin may suggest temporal arthritis, I said before, and additionally, because of the radiation of the pain to the jaw, could be mistaken as a dental problem. What about the very important differential diagnosis is Hashimoto thyroiditis. Hashimoto thyroiditis, the gland may be slightly tender and painful, but this event is rare, and the typical disturbance in iodine metabolism and ESR is completely absent in Hashimoto thyroiditis. And markers of inflammation, such as CRP, is very important. Even they studied in the saliva of the patient, they found it very high in subacute thyroiditis versus normal CRP in the saliva of patient with Hashimoto thyroiditis. But about the ultrasonography in Hashimoto thyroiditis cannot differentiate it. Both of them are hypoechoic. But when we combine to go to sonolastography, the subacute thyroiditis gland are more stiffer than cases with Hashimoto thyroiditis. And radionuclide thyroid uptake and scanning in Hashimoto is variable according to the level of the TSH, could be elevated, depressed, normal, but in subacute thyroiditis, radioactive iodine uptake is zero. What about functioning thyroid nodule, autonomous thyroid functioning nodule, and by manipulation can induce hemorrhage, so we can induce pain in the neck by simple manipulation, sometimes by the patient himself. So hemorrhage into a cyst in a nodular thyroid gland can be confused because of the pain with cases with subacute thyroiditis. Also the condition may be associated with autonomously functioning gland. And the hemorrhage usually is very suddenly and transient, and the fluctuating mass in the neck. But still the ESR is normal. Occasionally, the subacute thyroiditis can mimic hypothyroidism induced by exogenous iodine uptake. This event occurs probably in transient thyrotoxicosis following iodine therapy, but the sudden onset of subacute thyroiditis, toxic symptoms, elevated SR, and typical tenderness and pain in the neck is diagnostic of subacute thyroiditis. The problem only with cases lymphocytic thyroiditis cannot sometimes differentiate between both cases, and this condition is not related to iodine ingestion, but is completely, most probably, is a variant of autoimmune thyroiditis. The patient can present with goiter, mild thyrotoxicosis, and even low radioactive iodine uptake. and they pass in the same pathway of subacute thyroiditis, hyper, hypo, and normal. So sometimes it's mistaken, but actually the biopsy will differentiate it, and the goiter is painless most of the condition, and no associated symptoms of inflammation, myalgia, fever, and even ESR. What about therapy of patients with subacute thyroiditis? Most of patients, we don't need a therapy. However, many patients, sometimes severe pain in the neck, we can use some form of analgesics like non-steroidal anti-inflammatory agents and even aspirin, and they improve dramatically on them. But however, if this fails, the patient is not responding to non-steroidal anti-inflammatory medication and the symptoms are severe, we can go ahead to use corticosteroids. And large doses usually relieve symptoms through a non-specific anti-inflammatory mechanism, not directly related to the steroid itself. And usually we start by high dose of steroids, 40 milligrams per day, but a lot of studies found that just 15 milligrams per day can be effective in the treatment of these cases. And after 1 week of the treatment, the doses should be tapered to lower dose and continue for at least 6 weeks. And the relief of symptoms due to the use of steroids is drastic, and this could be a virtually diagnostic of subacute thyroiditis. Very new treatment option is the injection of lidocaine and dexamethasone through an insulin syringe in the thyroid gland, and it was superior even to the standard treatment by corticosteroids. An oral use oral cholecystographic agent in patients presenting with hyperthyroid state, and even patients relapsing after corticosteroid therapy. The recurrence rate of subacute thyroiditis after cessation of steroids is about 20%, it's not low. But no difference has been found in the laboratory data of both groups. And some doctors use levothyroxine to reduce the progression of the case and prevent relapses, but you have to use it after exclusion of hyperthyroid state. At that time, you release of thyroid hormone, and you have not to continue more than 1 year, because if you continue, you can induce permanent hypothyroid state. What about surgical intervention? Is not needed in subacute thyroiditis except the possibility of associated papillary cancer. Further cytological examination should be performed in patients presenting with a persistent hypoechoic area larger than 1 centimeter by ultrasonography. So it's suspicious of underlying problem, so we have to do biopsy and even surgical intervention. What about the prognosis of cases of subacute thyroiditis? In 90% of patients, there is complete and spontaneous recovery and return to normal thyroid function. We don't need anything. But sometimes in 2.8 to 4% with subacute cholera, it may recur. Up to 10% of patients become hypothyroid and requires permanent thyroxine replacement therapy. But however, the permanent hypothyroidism is significantly less common compared to the outcome tried by Professor Turceri about destructive thyroiditis like amiodarone. It is of interest that elevated levels of serum thyroglobulin over the years after initial dose, indicating that this inflammation is going on and it lasts for a longer duration. And if anyone likes, very elegantly, you have a chapter in thyroid gland presented by Rupindra and James. This is references, which is around 100 pages. Excellent to have reference for this subacute thyroiditis. And thank you.